everyone. This is Constance Payne with TennCare. I think we'll go ahead and get started here. Thanks so much for joining us today for one of our HealthLink webinars about behavioral health providers and chronic disease management. I really think this is a great topic for discussion. Hopefully you're able to have some of your other staff members join. If not, no worries. We will have the slides and the recording posted to our website as soon as we're able to get those files. Want to do a quick introduction of our speaker today, Dr. Chuck Cutler. He's a general internist, a medical director, developed integrated behavioral and physical health care programs in multiple states, and a former member of NCQA standards and performance measurement committees. Some of you recognize his voice and picture from some of our previous HealthLink webinars, so we're glad to have him back presenting on this particular topic today. And Dr. Cutler, I'll turn things over to you.
Great, thanks, Constance. Can you hear me all right?
Yeah, you will.
Great. So thanks for inviting me back. This is a topic near and dear to my heart, and I think there are a lot of opportunities for behavioral health providers to help improve the care of people with chronic illnesses, and that's what we're going to talk about today. We'll be taking questions at the end of the program, and the way I like to do that is for you to type in questions in the question box on our screen. If you have any questions, feel free to type those in, and we'll take them up at the end. And with that, we'll get started. We are going to talk this morning about the characteristics of the chronic medical conditions. As you'll hear, they're very similar to the characteristics of chronic behavioral health conditions. The barriers and challenges to the chronic disease management, you go about measuring success, and in addition, there are some resources and then an appendix with some additional resources. So as with many behavioral health conditions, physical health conditions often are lifelong. Once someone develops them, they often are with them for life. Some children may develop allergies or asthma or other conditions which are chronic in the short run, and they potentially grow out of them as they get older. But generally, after someone develops diabetes or develops asthma or chronic obstructive lung disease, those are things which really become a lifelong problem. They require a significant and consistent adherence to a treatment plan in order to improve. So some of the treatment plans may be more complex. Some treatments may be less complex. Sometimes they require multiple medications. Usually they require some kind of monitoring. And we'll talk a little bit about that. The thing that I think people with behavioral health expertise can bring is help in motivating people and understanding their motivation, first of all, and then motivating people to maintain their adherence to treatment plan. Sometimes that's facilitated by a tool like the Wellness Recovery Action Plan, or WRAP. I'm sure many of you are familiar with WRAP plans that you've used in your own practice. For physical health conditions, we take a similar approach where we try to understand what is it that's motivating people, what are their goals, what are their dreams, how can we take advantage of understanding what those goals and dreams are to help them their own plan, develop their own sense of empowerment so that they can contribute to the quality of their own lives. Well, it's clearly important to have medical professionals involved in their care. The vast majority of the time, people are not in their doctor's offices, hopefully, or in other medical settings, and it's really important that people understand how to manage their chronic illnesses, what they need to do, what they need to avoid, and also what to do when things aren't going as expected. Do they have a plan? Conditions do require regular follow-up. The timeliness of the follow-up is, in most cases, dependent on the severity of the illness or the consistency of the illness. They all require lifestyle changes. So many chronic illnesses require that people give up smoking or change their diet or develop an exercise plan or other kinds of lifestyle changes in order to be successful. It's not just a medication approach. People do benefit from peer-to-peer interactions, peer support, and social support. Again, I think many of you are probably very familiar with peer support specialists used to help people manage their behavioral health conditions. There have been a number of successful efforts using a similar kind of approach for chronic illnesses like asthma and diabetes, where a peer who has experience with those conditions supports people who are having challenges managing those conditions. I'll talk a little bit about that later. And lastly, it's really important to have a common understanding and coordination of care across all providers. Many physical health providers may not know that patients are getting behavioral health services or on behavioral health medications, and conversely, many behavioral health providers may not know that their clients are receiving physical health care on physical health medications. And this can lead to all sorts of problems. So just to give you some quick examples, people with asthma, for example, are often treated with high doses of steroids when their asthma flares. And if the patients also have bipolar disorder, for example, it causes them to be very agitated and hyper, and it can look like a manic episode, which is really due to the steroid. So it's important for people to understand, the behavioral health providers to understand when the physical health providers are prescribing medication. And conversely, the antipsychotic medications commonly used now often have an effect on diabetes and lipids. So a physical health provider, a primary care physician could be treating somebody for their diabetes and seeing their diabetes increasingly get out of control and not have to do to anything that the patient's doing or change in diet, but it could just be due to changing dosage or change amounts of antipsychotic medication. So the common understanding, the care coordination is really important. I'd like to give an example from a different setting. I know that people often are uncomfortable outside their usual practices, and behavioral providers often are uncomfortable asking about physical health conditions. Conversely, physical health providers are uncomfortable asking about behavioral health. I'm involved in a program at one of the national health insurers where we recognize that a significant number of people with chronic illnesses have depression, and their providers, their doctors, weren't asking about it, weren't even evaluating whether somebody was depressed or not. So we decided that with every outgoing phone call, we would have the nurses who were contacting people about their chronic illness ask them these two questions. I'm sure they're familiar to you. They're the PHQ-2. They're part of the PHQ-9. Full questions. They're not very complicated. But what we found was that the nurses who were making these outbound calls were uncomfortable asking these questions. They were perfectly comfortable asking people about their lives or whether they were incontinent or whether they were impotent or whether they had problems urinating or their sexual orientation or all sorts of things, which are also very intimate questions. But they were uncomfortable asking some of these questions. And what we found was it's not necessarily that they were uncomfortable asking the questions. They were uncomfortable because they themselves didn't have the expertise to be able to deal with the outcomes if somebody said, yes, that they have little interest or pleasure or they are feeling down or depressed. And we're asking them to do anything that really raised that question. What we were asking them to do was to refer somebody for a more intensive behavioral health evaluation. So similarly, what we're going to talk about today is just the reverse, which is that we're going to suggest that there are ways that you can interact with your clients, tell them about their physical health conditions, not so that you could change their medications or make any determination of what they should do differently, but really so that you could recognize that they need additional help and you can help them get that assistance from a primary care physician or the physicians who are treating them for that chronic condition. So there are gaps which we need to address in order to be successful doing that. The knowledge gaps, obviously, knowledge about the clinical conditions, knowledge about what to do when you identify them. There are data gaps, and there's some nice tools which are part of the HealthLink program that are available to help address the data gaps that can be very specific and very targeted to inform what should be done. There are patient gaps that each practice needs to for themselves because they're very dependent on the local situation, your relationship within the practice, your relationship to other providers, et cetera. Always challenges with implementation when you start to do things, and then the support both for the practices and the practitioners and the individual clients or patients that need to be addressed. So, how are we going to go about doing this? And you're seeing this thing in the upper corner of the screen, but I can't. Let me see if I can get rid of it here. There we go. So the first gap is a knowledge gap. And as I mentioned, the care coordination tool has a lot of very useful information that you could use specific to your own practices. So that among people with behavioral health problems, there are a number of disorders which are very common: COPD, asthma, heart disease, diabetes, obesity, tobacco use, and other substance use are very common. But the distribution of those may vary in different practices. And the nice thing about the care coordination tool is that it's something that you can use to identify the conditions which are most common in your practice, and then focus on those and get the additional education and support you around those conditions specifically, rather than just taking the general population distribution as a whole. So ways which we're not going to talk about today specifically, but I know there have been other webinars on how to use the care coordination tool to sort information, and that would be particularly useful in managing chronic illnesses. Secondly, there are people in your staff who probably feel very comfortable and have a good understanding of these chronic illnesses. So if, for example, you have nurses in your practice who have had a diverse experience, then they may need less support than therapists who didn't have the kind of physical health education that the nurses have had, for example. So social work programs or other counseling programs may or may not have any focus around physical health issues as part of the training, and people's experience may be solely in behavioral health. So in that instance, it's very useful to have some kind of basic education around the physical conditions which are common in your practices. So who can do that? There are a lot of ways in which you can get access to people who can provide this kind of basic information. There's a lot of information on the web. Obviously, that can be overwhelming. So I think it's often useful to have a partner to help address the educational issues. A strong relationship with a patient-centered medical home. If part of a patient-centered medical home, which I know some of the organizations are, then oftentimes you can draw on the physical health providers in those practices to help you with a Diabetes 101 or similar kind of educational program. Schools often have resources available, again, to do the same thing. Nurse schools also, and sometimes actually I think the nursing schools may be geared at a more appropriate level than the medical schools are for the staff in behavioral health practices. The medical schools need to remember that they're not trying to educate behavioral health providers to be physicians. What they're trying to do is provide some basic understanding and education. So depending on who you have good relationships with and who you find can help you successfully in these educational kinds of things are the ones who you could partner with. And then lastly, the advocacy groups, for lack of a better term, organizations like the American Diabetes Association or the American Heart Association or lung associations, or there also are associations for each individual illness, often have great resources. Those resources are often geared to the people who have those conditions, but many of them also have information for health professionals and have speakers that can come and speak to your staff. It is important to do this in a kind of structured way. So you would need to set up a schedule for education. The schedule could be lunch and learns, or it could be releasing webinars on a regular basis, or a variety of other educational methods. But having a set schedule, especially a schedule which engages people in a group kind of activity, often is more successful than expecting people to go online and learn on their own when they feel like doing that. There are a library of resources that are available virtually. I've included some references in the appendix that could be useful, and you can always add to that. Again, a lot of the advocacy groups have good information and searchable databases that are very easy to use. And then lastly, it's really extremely valuable to develop a relationship with people who are sharing in the care of your clients. Having conversations at the Learning Collaboratives, which is a nice ready-made forum with the patient-centered medical homes that are partners in care of your clients, is a great way to develop relationships. Having local conversations with them or inviting them to come to your facility or vice versa is really valuable. What we found, not surprisingly, is when there are interpersonal relationships between providers from different specialties, the communication goes a whole lot smoother than if you're dependent just on using a telephone list or trying to contact someone you don't have that relationship. So, what I've included here is some questions which are in a way analogous to what I was trying to say earlier with regard to PHQ-2. So here's some questions which you might ask people with asthma. I think asthma is common enough that I'd be surprised if everyone on the phone today doesn't have experience either with a family member or a friend or themselves who has asthma. The intent of these questions is not so that you would be trying to address problems or negative answers to these questions, but really intended to do two things. One is identify people who are really having problems so you could facilitate their care with a primary care provider sooner than they would on their own. People with chronic conditions sort of write off exacerbations when they really should be getting care earlier. So it could be very helpful in helping people identify that. And secondly, some of the questions are questions which really are prompting your clients to ask their primary care physician. People often don't know what questions to ask, and to help them understand, these are the kinds of questions that you could ask your primary care provider, really is very valuable to them. Again, these are simple questions. Are you using your inhalers? Many people who have stable asthma don't use their inhalers regularly, and that's just fine. On the other hand, if they're having problems, they should be. Doctor tell you to use them? Do they understand how they're supposed to be using their medications? Have increased their use lately? If people say they've really had to increase their use lately, obviously the question then is, when's your next appointment? And if your next appointment is 3 months from now, that's probably not adequate. That's the kind of question where you could be very helpful in arranging a sooner appointment with the appropriate provider. Do you understand what you do when your asthma is bothering you? So again, this is a common question across every condition, and you could substitute any condition for asthma here. A plan should include something called a symptom response plan, or it's called different things, but symptom response is probably the clearest. People with chronic illnesses should understand what they need to do when their symptoms worsen or their blood sugars worsen or something is happening which they feel is not their usual state of health. What do they do? And in some cases, what they do is manage things themselves by adjusting their inhalers or their insulin dose. But in cases, it means getting help sooner rather than later. So it's important for people to have a plan. And if they don't, then this is one area where you should really encourage people to their primary care provider, develop a plan. Sometimes, again, it's very useful to have multiple people involved in developing that plan. So a conference call with the physical provider, the behavioral health provider, the person who is supporting the client, family member, or friend, or whomever, sometimes is extremely valuable. And then the last question is just, how are you doing today? How's your breathing today? And if the answer is, I'm doing all right, great. If then it may be helpful for you to arrange follow-up with the primary care provider sooner rather than later. Similarly, there are a series of questions for blood sugars. How has your doctor advised you to check your blood sugar? How often? Do you know how to do that? Are you doing that? What has it been in? Is it in your usual range? And people should know what range their doctor feels is usual for them. You want someone to have a blood sugar 100, 125, something like that as a baseline blood sugar. People have different sensitivity to their medications, and sometimes their doctors will allow them to have a much wider range of blood sugar because they've had problems have low blood sugar. This isn't something where you should intervene, but the person should be able to answer the question, what range has it been and what range does your doctor want it to be in? Higher low blood sugars, again, that's a trigger question. If they say, yes, I've had recently more low blood sugars or high blood sugars, that's something which should trigger, help them get a visit with their primary care provider sooner rather than later. To watch out for and what to do if sugar's out of control. Questions which you don't answer, but that they need to raise with their primary care provider. So for diabetes, for example, usually people have some, quote, panic values, unquote. If your blood sugar is less than X or greater than Y, then they should call their primary care provider, or for people who have a very brittle diabetes, you need to go to the emergency room. So, again, these aren't things which you need to address directly, but these are the kinds of questions your client should know about, and if they don't, then they need to have a conversation with their primary care provider, which you facilitate. Again, the reason I say you can facilitate is sometimes people will call their doctor's office and ask for an appointment, and the doctor will say, well, the earliest appointment is 3 weeks from now, when they need to be seen sooner. So having another professional call the care provider, especially if you have a good relationship with that primary care provider, can really facilitate an earlier appointment and better care than just the patient or the client to do it on his or her own. Some other questions. These are for diabetes, but I think they're generic enough that they, again, could be applied to any condition. And these are questions where someone with a behavioral health expertise could really be very helpful in engaging people in self-management of the care. what does it mean to them to be a person with diabetes? And how do they feel about that? They feel about changing their habits. Virtually every person with diabetes, unless they've had diabetes for a long time and are well controlled, need to change at least some of their habits. They need to focus on diet consistently over time. They should have a regular exercise program. They shouldn't be smoking. They should monitoring their blood sugar, monitoring their blood pressure, etc. So there's a lot of self-care that goes into the management of diabetes, also for heart disease and COPD. And it's important to understand their motivation or barriers to doing that. And oftentimes, these are areas which are not explored by the primary care provider. Often primary care providers don't have people in their practices who can assist with this kind of evaluation and support. So again, a partnership between the health provider and the primary care provider can be extremely valuable, again, especially in patients who have behavioral health conditions and serious mental illness. Often need support in developing the self-confidence and help to make changes in their behavior. And many people with behavioral health conditions see their behavioral health providers more frequently than their primary care providers. So you could do anything that you could do to help them address their motivation and improve their self-confidence and their ability to make changes and manage their condition is extremely valuable overall. Management of chronic conditions. This slide is something that I've taken from a previous presentation that you may have seen. These are the kinds of things where your intervention can really be helpful to people in managing their illness. Do they have a basic knowledge around diabetes? Are they aware of the standard kinds of prevention or care or lifestyle changes, et cetera? Can you help them reinforce what it is that they're doing, where they've been successful, and address the barriers where they haven't been successful? Self-efficacy is something which I'm sure you're addressing with any behavioral health condition all of the time. And here to combine that support for self-efficacy for the physical health conditions, again, is extremely valuable, helping people develop the confidence and comfort in managing their own conditions, identifying the barriers and the benefits, and helping them overcome the barriers and recognize the benefits, which oftentimes they don't, is very valuable. And then helping people understand and facilitating care when needed, preventive care and acute care is extremely valuable. Now, what about the data? So, again, care coordination tool is a great resource here. If you don't know what conditions your clients have, you can't help them. Same is true for the physical health providers. So, you may not, and I've seen this both in physical and behavioral health practices, have a complete list of the diagnoses, of the medications that people are experiencing. So using the care coordination tool to identify each clients and to see what diagnoses and patients are listed of those clients, making sure that all of those are in your clinical record, and the same on the physical health side is extremely valuable. I've seen things as serious as someone being treated for AIDS, not someone who is HIV positive, but someone who had active AIDS being seen by behavioral health providers. Behavioral health providers didn't know that had such a serious underlying illness. So it's important to capture that information in a way that people in practice can see and see easily. So it should be in your medical record, your electronic record, and agreement on where these are going to be noted. If they're in different places across the medical record, people aren't going to know to look for them, or they'll spend a lot of time looking for them unsuccessfully. So agreeing on where you're going to capture these diagnoses in a problem list or diagnosis list, or someplace in the record that everyone understands where they can see kind of information, is extremely helpful. The care coordination tool has a risk stratification, which identifies who most at risk with their various clinical conditions. And these are people with whom you want to raise issues sooner rather than later. So you may not be able to address all of the conditions for all of the people at all visits, but identifying people who have a high risk score or a particular common chronic condition that you want to address, or people with recent ER visits or hospital admissions, are people who you want to focus on. Those are the people who are most in need. And again, unfortunately, sometimes the follow-up's not really adequate, that the hospital doesn't arrange follow-up, or the person isn't able to get transportation, or whatever the event is. If you're seeing someone in your practice who was discharged from the hospital last week because of an asthma exacerbation, it would be important to ask them when's their next follow-up appointment with their physician. And if the answer is they don't have one, or they have one in 3 months, that's probably not adequate. They need to be seen sooner. By the way, hospital readmissions, one of the best predictors of readmission is not having a visit within a month after hospitalization. So someone who's been admitted to the hospital with an exacerbation of diabetes or heart failure or asthma, it's really important for people to be seen in follow-up, excuse me, as soon as possible after that hospital admission. Who is going to update the record? I say this because some practices find that it's really useful to have someone who's dedicated to doing this. It could depend on each individual practitioner to update the record as they see the patient, but oftentimes it's easier to have someone whose job it is to use the care coordination tool to look at the people in your practice either by panel or by schedule, and oftentimes schedule is the easiest way to do it. Whoever to be seen in the next day or the next few days, and then put that in the record, and in some cases put a flag of some sort that will get the attention of the provider who they are seeing. So this could be administrative staff, this could be a care coordinator, this could be, sometimes I've seen practices even use students who are doing a clerkship in the practice, or other people who obviously need to have some understanding of the clinical picture, but in particular understanding of how the record's structured and agreement about where they'll note this information. And again, you can identify those people who are high risk, make sure that that's called out so that the provider who's seeing them can make sure to focus on their physical health condition as well as their behavioral health condition. What to do after asking people the questions, or sometimes patients will just volunteer that they're having a problem. Again, unfortunately, I've seen people come in for a behavioral health appointment, in particular if they haven't been seen in a while, and will obviously be having some clinical physical health condition. And there needs to be a method for communication between the behavioral health and the physical health provider that works for both practices to be successful. If you don't have an agreed upon method and you expect a response from a health practice, you'll likely get the response which you might give if the reverse were true, and you don't know the providers well enough to be able to exchange information smoothly. So if, as often is the case, your practice has a patient in another practice, a physical health practice, agreement on how the communication and coordination will work is really important. The easiest is the non-acute referrals. So someone comes in, their asthma's under control, they haven't had a visit in a year, let's say. It would be good for them to have a visit. That's straightforward. Acute care is much more challenging. We'll get to that in a minute. But even for those non-acute referrals, it's really valuable to share the treatment plans and medications and a method to share information when the medication is changed. Some medications will affect multiple conditions that changes, particularly in antipsychotic medications or anti-anxiety medications, can have effect on physical health conditions and vice versa. Escalation protocols means as a condition worsens, is there agreement on what to do? Agreement on panic values or acute symptoms or other things which would cause you to more acutely refer someone to a practice. And lastly, what I've often found is that case coordination, case conferences are really valuable, and they're valuable in a few ways. One is they're very valuable to the client because sharing information directly with the other treating providers oftentimes surfaces issues that weren't recognized and might not be recognized with a more passive kind of communication. So an example is we put together a case conference for a patient who had multiple visits for abdominal pain and to the emergency room and was evaluated in the emergency room. They didn't find anything physically wrong with the patient. They told the primary care provider, Mrs. Jones was here. She was here also 2 weeks ago. We did the same evaluation. We didn't find anything wrong. She's complaining of abdominal pain. And the primary care provider just sort of shrugged and said, well, you know, I don't know what else to do. She's already had the evaluation in the emergency room, but had the thoughtfulness to say, well, you know, she's all being seen by the behavioral health providers. Maybe we should have a conference call. On the conference call, it turned out that she had been started on some antipsychotic medication, which is a side effect of abdominal pain. And by recognizing that and changing her medication, the two practices were able to address both her physical and behavioral health condition at the same time. So that's the explicit value for the providers and obviously for the client. The more subtle kind of value is that kind of relationship really leads to much smoother communication and much better communication and care that benefits the clients in a very unique way. And again, unfortunately, our healthcare system is not set up to support that kind of communication. So by having you develop that kind of communication process, a regular communication process, and easy sharing of information, and most importantly, ongoing relationships with the primary care providers is valuable to everybody. How are you going to do this? So let's say someone comes in and they are having an acute problem. Who's the one who's going to make the call? Does the patient take time out of their clinical schedule to do that? Do you have a central coordinator who could do that? Their administrative staff or reception staff that could be identified to do that. Conversely, medical health providers side, who are you going to call? Do they call the receptionist? Do they want you to call a special number? Do they have a care coordinator who manages referrals, et cetera? What's the best way of communicating? Is it a phone call for acute events? Is it email for other kinds of events? Is faxing better? And these sound sort of simple, but the more you could identify them up front and the more you could have the communication process clear, the easier it's going to be for everybody. And true in the reverse. So, you know, in many cases, the primary practice are going to recognize someone who really needs some behavioral health support and intervention. What do you want them to do? Who do you want them to call? How do you want them to communicate with you? for very acute things, how are you going to manage transportation? How to manage other support that the client or patient might need? And what process are you going to use to follow up? What you want to do is to be sure that people have the appropriate follow-up and care that they need, but not have duplication of effort or confusion in who's doing what, because the more people contact the patient after the fact, the more confused the client gets, and actually to some degree it makes it less likely that they'll get the follow-up that they need. As you start to implement the processes to support this kind of holistic care, everyone in the practice needs to understand that change is hard. There'll be challenges and hiccups about the implementation. You can expect some bumpy roads in the communication between primary care and behavioral health and vice versa. And that's just all part of the process. And it's something that you need to address as it comes up, not sweep under the carpet, but recognize that there are going to be these hiccups and just have a process for dealing with them. As providers start to address areas outside their clinical comfort zone, may need some support. And what I found in that story that I told you earlier about asking the PHQ-2 was that what was most helpful for the nurses was, first of all, if we could co-locate behavioral health staff with the physical health nurses so they could develop ongoing relationships, that was the most successful. In some cases, we weren't able to do that, but what we're able to do is to introduce people individually. So the providers each got to talk to each other and got to meet each other and start to feel more comfortable about the relationship. That can overcome a lot of the concerns that people have. So just knowing that they have somebody who knows them, where they could pick up the phone and say, gee, I'm not sure whether this is important or not important, can add tremendous value and help people feel much more comfortable about asking things outside usual professional areas and their usual comfort zone. The behavioral health providers may not know where to refer people necessarily. Should it be their primary care provider? Should it be the emergency room? Should it be somebody else? How are we going to deal with that? It would be good to have a resource that can help you solve those problems and develop protocols, or these simple protocols that will be helpful to people. And on the flip side, you should be aware that once these relationships start, that the physical health providers may recognize more people with behavioral health concerns and want to refer them to you, and you may not be able to handle the volume. So how is that going to work? How are you going to triage? What sort of communication process do you have in place? The physical health providers, again, may need some support from you in developing their own protocols and their own questions so that they could feel more comfortable managing, especially some of the people with the more common, less acute, less complex conditions like depression and anxiety, and sort of reserve the more acute kinds of referrals to the more complex people, like people who have schizophrenia or bipolar disorder. There are a number of organizations which can be helpful to you. As I mentioned earlier, they can be helpful to your clients directly by providing educational programs and materials. They can be helpful to your providers, the Heart Association, Lung Association, Diabetes Association. There are a number of community organizations, depending on which ones are active in your community, that also have programs and can be very helpful, especially with regard to lifestyle changes. MCA certainly is one of them, and they've been taking a much more active role over the last few years in the management and support of people with chronic illnesses. Churches and faith-based organizations increasingly are having programs. There's been an active effort in some communities, the African American communities, to engage churches to help screen and support people with conditions that are common in the African American community, such as hypertension, for example. Other health professionals in the schools are especially valuable in supporting children. So in areas where there's a high prevalence of asthma, for example, among kids, helping the clients recognize, but also having a relationship with the professional in the schools that nurses and counselors and others in the schools can be helpful to them, expand the range of support that people have, again, that can be extremely valuable to them. We found some businesses to be interested in providing support as well. So I've worked with chain supermarkets that offer nutritional counseling and shopping support. Doing that in your community, it's really valuable. We arranged in Iowa, for example, to have one of the supermarkets have their dietitian meet people with serious mental illness and help them do their shopping and plan their meals. And the supermarkets found it useful in increasing their volume, and obviously the clients found it extremely valuable. While many pharmacists don't have the time in their busy practices to do education, some pharmacies are supporting patient education. And again, if you have a relationship with them, they may be particularly valuable in helping people who have medication. So how to know how you're doing and whether you're making progress or not. It's best to start with those things which are really simple and easily measured. So some sample measures, for example, include just looking at a sample of the records and seeing are all of the diagnoses, both physical and behavioral health conditions, included in the record. Does the treatment plan mention anything about the physical health conditions? Anything about support or counseling or referral to primary care or anything which would indicate that the provider had engaged with the client around their primary care conditions? Is there involved in any of the other health link support activities? You can use the care coordination tool to look for things like, has someone had a PCP appointment? If they haven't had a PCP appointment in a year where they've been seeing your providers, again, likely means that someone either didn't mention it to them or didn't know that they hadn't had a visit. It'd be useful to trigger a change in your process. Quality measures also, which are being tracked. So you can look to see whether the diabetes measures like hemoglobin A1C are being done or improving. Are fewer gaps in care than what there were previously? And is there an increase or hopefully a decrease in number of ER visits or hospital admissions for the clients in your practice? You can do that with a simple chart. These measures are just measures that I'm proposing as sample measures. You could develop your own chart, but it would be important to take a look at how you're doing. If you just assume that everything's working well, you'll be surprised when at the end of the year you look at how things have gone. So I'd advise you to start doing this in the first month or the latest in the first quarter, just to see how everything's going. And there are a number of resources included here, which are sort of basic information about the most common conditions. And with that, I'll stop and see if there are questions.
Chuck, so just as a reminder, if anyone has any specific questions for Dr. Cutler, you can put those into the chat function and send those along. Also, feel free to reach out to Mary or myself. This is Constance. If you have some questions after the fact, we can get those to Dr. Cutler and get responses. Or if you have questions about how components of the program interact with the information he's presented today, you can also send us those questions via email. And we'll give folks a minute or so and see if you've got any questions. And as a reminder, we will be sending around the point presentation as well as a recording. We'll be posting that to our website. So I will let HealthLink administrators, and actually I can just send a reply email to the invite, the calendar invite on this. So if you know of any members of your organization that weren't on that original calendar invite or don't see those HealthLink updates, make sure that you touch base with your HealthLink administrators if you are looking to have access to that actual presentation. Well, we aren't seeing any questions, but again, as always, if you think anything else that comes up, please let us know. And thanks so much to Dr. Cutler for taking time out of his day to present us with a good overview of these materials. And just to let you know, we'll continue to have dialogue around this topic within the learning collaboratives and at the conferences, and if you are still participating in on-site coaching and would like to delve into this topic a little bit more, that's something that you can mention to your Navigant coach, and they can work on working that into your schedule for coaching. So thanks again, everyone, for joining us, and we'll see you next time.